So I'm super excited to be here today and really excited to talk to you about my more recent work on the impact of Medicaid expansion on the financial well-being of low-income adults. I started my career as a medical social worker working in an emergency department, and really, in the emergency department, the intersection of health and poverty is so obvious. And it's long been an ambition of mine to be able to get, deeper into where these two things intersect, and this work represents that. And so I'm excited to share it with you for that purpose, but also because one of the papers, the evictions paper, has not yet underwent peer review. So this is a really good chance for me to get some feedback from you on your thoughts, on things you think we should have considered that we didn't, on the framing, just anything that you have to contribute. I brought a pen and I'm ready to learn from you, and I consider it just an honor to be able to be here and talk about it. Before I start, I want to acknowledge the funding for this study, which is the Russell Sage Foundation. For anybody in the room that is interested in studying the Affordable Care Act, the Russell Sage Foundation has a mechanism to allow you to study the non-targeted impacts of the ACA. So not health access, not healthcare utilization, not health outcomes, but other things that you think might be happening as a result of the ACA. So I received funding with Tal Gross, who's an economist at Boston University, to study that. I want to thank my co-authors. I have talking about two different papers, and so I have different co-authors from each, but of course I'm representing all of our work. And I want to thank the Center for Health Administration Studies for bringing me here and for this very cool speaker series that you have. I only wish that I could be here to attend it. I've looked at your lineup and it looks like it's a lot of cool people. So the impetus for this study is trying to get at the relationship between health and poverty. And backing out a little bit, it's important to consider that health and poverty changes over time. I mean, if you just take a lifespan approach, people tend to be healthier when they're younger, and they tend to get unhealthy as they age. And people have different times of their life where they might be exposed to poverty. And poverty can impact health, and health can impact poverty. And yet it's been very hard for researchers to study that intersection. We have a few longitudinal studies, but you have to hope that they ask the right questions at the right time, and often that's not the case. And so I think it's really difficult sometimes as researchers to try to capture that moment where somebody's health might impact their income and where it might impact their standard of living and their well-being. Or when being in a high poverty situation can impact your health. And so still just trying to get at that and running up against data limitations all the time. But I think that as more and more people get on the Medicaid program, we're going to have a better understanding of how these things work, intersect over time. So being uninsured has long been considered a reason why people might experience disparate health outcomes. People in poverty are more likely to be uninsured. I don't know if that's actually the case anymore in Medicaid expansion states, probably, but it has long been shown in the research that the poorer you are, the more likely you're not going to have employer-sponsored insurance. And so the policy context that you're probably all aware of was the Affordable Care Act Medicaid expansions in 2014 and Marketplace expansions also in 2014. And the SCOTUS decision, if you're not aware, was a decision by the Supreme Court to make Medicaid expansion optional. And to me, it brings us to one of the greatest polity inequities in our country, which is that in states that didn't expand Medicaid, if you make a little bit more money, you can get almost fully subsidized private health insurance through the Marketplace. And if you're poor and your state didn't expand Medicaid, then you don't qualify for the subsidies if you're below 100% of federal poverty level and you remain uninsured. So when you think about the ACA as a tool to reduce health disparities, this decision and the differential expansion of Medicaid kind of reintroduces this opportunity to have enduring health disparities. And so when the research that I've done on Medicaid, one of my primary objectives is to inform states that have not yet expanded Medicaid about why they might want to do so, or concerns that they might have, things that they could do to improve the program if they did. The reason why we're focusing on, in these papers, payday borrowing and evictions is these are both adverse financial outcomes for low-income people. They are disproportionately affected by it. So if you are low income, you're more likely to experience an eviction. You're more likely to go to a payday lender. Research by the Pew Charitable Trust has found that lower income people are 60% more likely to use payday loans. So it's a problem that disproportionately affects them, but it also has all sorts of implication for their well-being and their health. If you lose your housing, that could disrupt your ability to go to work. It could put you in dangerous living environments. You could become homeless. Also, if you have a big health crisis, that could make it hard for you to work, and then you could be put into poverty and be more likely to be evicted. And with payday loans, which I'll talk about a little bit more in depth, they can cause real trouble for people in terms of getting back on their feet financially. So that's why we picked these things, and we have reason to believe that Medicaid might actually make a difference. So some mechanisms, and part of me is like, oh, this is like from the center of the patently obvious. A lot of my research feels like that way, like, oh boy, you wouldn't guess, but I understand that this is obvious, but if you're ever going to do a study design, you have to kind of say why you think something will happen. So I'm going to walk you through why I think this will happen, and I apologize for how obvious it is. So if you have Medicaid and you get sick and you need care, and you will pay less for it than if you have to pay for it out of pocket. And there's a lot of kinds of care that people use when they're uninsured. That they are required to pay for before they're able to use it. Urgent care is often, if you're uninsured, they want you to pay a set price for your visit before you come in. And I think another really good example is prescriptions. So say you manage to get access to care through some way, and maybe they're willing to bill you, you still have to go to the pharmacy and you have to lay that cash down. So what we know is that Medicaid provides a very good pharmacy benefit, and we would expect that people that get Medicaid will not have to spend that much money, and that they would have that money for other things. It might increase health to the extent that it impacts earnings, which could mean that you do better at work, that you get more likely to get promoted, that you're more likely to be able to get a job. I don't know if I would pick that as a primary explanatory variable. Medicaid populations have historically weaker ties to the labor market. With the Oregon experiment, we didn't see, paper that Kate wrote with Amy, we didn't see any changes in labor force participation related to Medicaid. So I don't know, but it is a possible mechanism. And the money that you save from not spending that out-of-pocket payments, and the money that you might get from increased wages can be reinvested in your life. In terms of thinking about evictions, it could be reinvested in housing stability. In terms of thinking about health, it could be reinvested in nutrition. There's all sorts of mechanisms we could kind of think of where we would expect Medicaid to have a positive benefit in terms of these outcomes. So there's also prior evidence to support this relationship. So the Oregon Health Insurance Experiment found that Medicaid reduced out-of-pocket spending in general, but almost entirely eliminated catastrophic health exposure, which we defined as 30% of your income. It reduced financial strain, and that measure is like a really important measure. It's like, did you have to borrow money from friends and family? Did you have to skip paying some bills to pay other bills? That like robbing Peter to pay Paul. And it reduced your probability of being in collections, primarily because of medical collections, and if you were, you owed less. So that's one positive benefit we know from Medicaid and finances. There's also been studies on Medicaid and credit scores. What I like about those studies is that credit scores like evictions and payday loans can have real serious implications for low-income people. And what they found in this study is that health insurance improved people's credit scores to the extent that they got better credit offers. So the terms of credit that they engaged in were more favorable to them, and the authors estimated that that value was at $520 million per year. So think about that. You go to get a car and you're not paying a 10% interest rate. You qualify for a loan at 5% interest rate. These are the kind of what I think of as manifold consequences of either having a good financial health or bad financial health. And there's been several systematic reviews of the ACA expansions, and while there are some things that are contradictory, one of the consistent findings is that Medicaid is good for people financially. And there has been studies on medical-related bankruptcy that showed that insurance is protective of medical bankruptcy. There was a recent study to say that maybe it's not quite as big a problem as we previously thought, but there is still a literature to support that. And so the research questions that I'm going to share with you today in the studies that I'm going to present are on those two questions. Could Medicaid impact payday borrowing? And could Medicaid prevent evictions? And in both of these papers, and the reason I decided to try to shove two papers into one presentation is they are very complementary, and one of the reasons they're complementary is that we focus on California in both studies. And the reason we do is not because California is the Mecca, though you in Chicago might think it is because it's so warm, but we had data limitations. And one of the biggest data limitations is always the lag time between when something happens and when data comes out that's about what happened. And in this case, the payday loan data that we got did not allow us to evaluate the Affordable Care Act expansions in 2014. And the evictions data set that we had did not have enough control counties. So the majority of the states that we had evictions data for were treatment states. And so it really would have been difficult to make a case that that was okay to do. So what we decided to do is to focus on California's early Medicaid expansion. And it, there's strengths and weaknesses to that, but we follow the kind of methodology set by Ben Sommers and colleagues in a 2014 Health Affairs article where they list the dates of expansion. California expanded over a period of time from 2011 to 2012, and they did it on a county by county basis, and not all counties expanded early, though most of them did. And that variation allows us to consider what the impact of Medicaid expansion might be on later expanding states. There's about 3.8 million Californians who gained coverage during this early expansion. So the first paper, let's just dive into it. How many of you, I don't know what happened. Wait a minute. How many of you recognize this? Anytime you drive into a low-income neighborhood, you're going to see a lot of these. And this is a payday loan storefront building. About 12 million people borrowed, had a payday loan in the last number I was able to find, which was 2012. And payday loans are specifically for people that are working and can demonstrate that they have money coming in. Now, to be clear, it's not that people can take money out of your paycheck if you don't pay it. It's just some way of demonstrating that you have income, and then you apply for a loan, and you're still responsible to pay for it. But the assumption is if you can demonstrate you have a paycheck coming in, then payday lenders will assume they're getting paid. And the loans are pretty small, between $300 and $500, and they're supposed to be paid back in 2 weeks. And they usually have a set fee per $100 that's lended, and well, this is not a great outcome, and we do look at this, you can roll that over generally. So it's the end of your 2-week period and you're like, I don't have enough cash to pay this. And they're like, well, we can issue you a new loan, give you an extra $50 today to bring you to this, and then you have to pay it 2 weeks after that. And this is where, when you think of like a debt spiral, where this can start to really happen. A lot of people don't like payday loans. Payday lending is a practice. There's been a lot of initiatives from a policy level to do away with them. And there's good reason to be concerned about them as, you know, kind of a financial option for low-income people. They are very expensive when you consider it at APR level. The percent is usually 300% to 400%, which is way above what you would pay with a credit card. When you give people information about what the costs really are, they often choose not to take it, which tells you that it's kind of a loan of last resort. You know, when people understand what they're getting themselves into, they recognize that it's not ideal. They're advertised as like, we're here for you when you have an emergency, but that is not how people use them. In a survey of payday borrowers, the Pew Charitable Trust found that like 70% of people were not using them for an emergency, but we're using them for reoccurring monthly expenses. And you can see why that would be problematic, right? You're gonna have to pay that same amount next month. So how is next month gonna be different from this month if you don't have enough money to make ends meet? And payday borrowers tend to borrow frequently. So it's not that somebody takes one loan and then 2 years later they take another loan. And I'll show you the distribution here, and it's pretty remarkable. I was going to say, the thing about unexpected expenses versus routine expenses is healthcare can be either, right? When you think about why health might impact people's payday borrowing, you can have an emergency that means you have to suddenly come up with a certain amount of cash to buy a prescription, for example. Or you might have a monthly prescription cost that you just can't afford to pay. And every month you come into conflict between, do you pay your heating bill or do you get your prescription? And there's a long literature of low-income people skipping doses of their medication, taking half doses of their medication. And so we know this is a real barrier for people. So this is what the distribution of the number of payday loans looks like for an average borrower. The average is 8 loans per year. That is not a short-term relationship with a lender that's meant to get you out of a hard time. That is basically a budgeting strategy that people are having to use. In defense of payday loaning, or payday lending, this very scientific formula above is mine, so I don't want anybody to borrow it. But it comes down to, if you don't have a choice, it's better than nothing. And that is a real argument that people use. If you have bad credit, people aren't going to lend you money in the conventional banking sector. You can't come in and say, I'd like a personal loan. They're going to look at your credit score and they're going to say no. And so when you do need to come up with cash quickly, this is an option. And there has been some literature to suggest that alternative arrangements aren't any better. And I want you to consider checking accounts. If you write a check for $2 and it bounces, you're going to have a $25-ish fee. If you write 10 checks and they're all under $20, you're paying 100% in a penalty of what it is that you borrowed. So that quickly can become worse for people, and that actually is another strategy that low-income people employ to try to make things work. So I'm going to post-date a check to the electric company and hope they don't deposit it until this date. I'm going to, post this check here, and then I'm going to go see if my mom will give me some money that I can deposit to cover it. So it can become very problematic, and in some ways, I think that probably is worse for people than just taking out a payday loan because their fees can be much higher. And the last defense of payday lenders is that they are actually not as getting as rich as people think they are. I mean, there's this idea of they're a predatory lender, and that predatory, the beast, like it's coming in and taking out the little guy. But if you look at the amount of money that they actually get back, they lose a lot of money. And that is what drives the fees up. So when you're giving money to a population that has a history of bad credit, there's the possibility that you're not going to get paid. And if you're not going to get paid, you have to recoup that money from somewhere, and where you recoup it is from new people that come and borrow money. So those are just some things to think about when we think about the policy implications. So the data that we received was from Clarity-CFSA. It's a Community Financial Services Association of America. And they are a, how would I describe them? They are like a business association for payday lenders. They collect data, they do federal advocacy. On behalf of payday lenders, they monitor changes in the policy, and they gave us a data set that was de-identified for the purposes of this research. And I have to say, they did not impose any restrictions on us whatsoever in terms of the research question we asked or the findings. We didn't have to run any of our papers by them for their feedback before publishing, and so we're really grateful for that. The data set that we got was from 2009 to 2014 and contained the universe of the 5 largest payday lending chains that had locations in multiple states, and I'll show you a map here in a second. And the time period we have is approximately 2 years before and after California's initiated their Medicaid expansion. For each loan, we know we have an encrypted social security number, which allows us to look at multiple borrowing patterns. We know when they got the money and when they were supposed to repay the money. We know the zip code of where the storefront was at, and we know whether, what happened after they got the loan. And this is what our map looks like. So the gray area means we don't have data. And it's important to know that 12 states outlaw payday lending entirely. And about 28 states are what we call permissive, meaning they don't regulate it a lot. And California is an example of a permissive state. This is what our sample statistics look like when we compare our Medicaid expanding counties in California with other counties around the country that did not expand Medicaid at that time. We have 43 counties in California and 924 comparison counties. There are a lot of loans in the data set. This just kind of compares the demographics of the age and how much people are using payday loans. And our approach was a standard difference in difference design, where primary outcomes is we wanted to look at how many loans people took out by how many unique borrowers and how much they borrowed. And then we had some secondary outcomes, which ended up being more trouble than they're probably worth, but I'll present it to you anyway. And that's the number of people who default, the number of people who pay late, the number of people who roll it over into a new loan, and then the number of loans each person took. We stratify, we focus on people under the age of 65 because those are the people impacted by the Medicaid expansion. And we stratify it because most of California's enrollment was a younger population rather than older. So 80% were under the age of 55, and half of them were under the age of 50. So we wanted to look, because one of the, we don't have a lot of variables to work with here, and so we're trying to get at as much as possible something that would allow us to specify that relationship between Medicaid and the outcomes. So we would expect that we would have a greater impact among younger people based on the demographics of who enrolled in Medicaid in California. And then we also stratify by counties, because we would expect that there would be a bigger impact in counties that had a larger share of uninsured prior to the expansion. And then we do what's called a triple difference in difference, where we compare those over the age of 65. So we look at Medicaid expanding counties compared to non-expand counties over time, comparing those over age 65 to people under age 65. So here's our results. We found that Medicaid expansion was associated with a significant reduction in the number of loans, the amount that people borrowed, and the number of unique borrowers. The number of loans represents an 8% decrease in loans. There's a 10% decrease in the dollars loaned and an 8% decrease in the number of unique borrowers, and all statistically significant at conventional levels. That's what's in the brackets there. I'm going to show you a graphical representation, and this is not the graphical representation that you would see if you read the Health Affairs article that this paper comes from, because we had an editorial difference of opinion about what it should look like. And because I get to exercise my opinion in this venue, I am showing you the graphs that I would have liked to seen in the Health Affairs article that did not end up happening. So I believe they should be on different axes because they're very different levels of measurement. The number of loans versus the dollars of loans are very different. So I'm presenting them the way that I like it. And if you go into, I use my example of my exhibit from the Health Affairs article in my class on how to lie with statistics. I'm like, look at this. This is like bad presentation of data. Don't tell the editor of Health Affairs I said that, because they're reviewing the Payday or the evictions paper right now, so I want to stay in good graces. But this is just the difference with the confidence interval, and I think it's helpful to see that for each of those outcomes, we do observe a pretty decent drop. This is an event study that helps us kind of test the parallel assumptions trend of the difference in difference model. So as you can see, that prior to the expansion, the trends in Medicaid expansion counties was very similar to the trends in non-expanding counties. And then after, about 6 months after the expansion, you start to see this downward trend in Medicaid expanding counties compared to those that didn't. So this is very reassuring in terms of our methodology that the approach was appropriate and okay. When we look by the age of borrowers, what we see is that it's entirely driven by people who are younger. The 50 to 64 does not reach statistical significance, and the reduction is concentrated among those between the ages of 18 and 49, which is kind of what we see with the Medicaid expansion. So that's also kind of reassuring that, that the enrollment trends seem to match the trends in the reduction of payday borrowing. When we look at people with the share, previous share uninsured, we also see that it's the people in the high tercile of previously uninsured where we see the biggest reductions in payday borrowing. You can see, just comparing high versus low, that the magnitude of reduction is consistently greater in these areas where there were people that would have benefited from a Medicaid expansion. So in summary, our main results, we believe that Medicaid expansion is association and reduction in the use of payday loans. We see the effect is larger among younger borrowers and in areas where they previously had more uninsured. When we look at secondary outcomes, things get a little crazy. We see that the age went down of the borrower a little bit, which you wouldn't totally expect. It's a statistically significant difference, but I don't know how much of a meaningful difference it is in terms of actual differences in age. We see the share of defaults go up. We see the share of late payments go up, and we see the share of rollovers go up while the number of loans per borrower goes down. I'm going to talk about this in a minute because we have a theory about it. Can't test it yet, but it's interesting. Yeah.
I just have a question about the age effect.
Yep.
So basically what you're saying is that age here is standing in for a proportion that are potentially covered by Medicaid. That's how you're thinking about it? Because to me it seems the older you are, the more you would expect the Medicaid expansion to have more of an impact on older people because they tend to be sicker, right? But you don't have, these aren't people, you don't know who's on.
We don't.
So
that's right.
Standing in as a proxy for enrollment, right?
I mean, we found it reassuring because you would expect to see greater reductions where you have more people who gain coverage, but you're right that the magnitude and need might be different, and that's true. Yeah, it's good to think about. Yeah.
Back on your last table of results, we usually don't pay a lot of attention to R-squareds, but these are huge.
Mm-hmm.
How is it, what do you think about being able to explain so much of the variation in these outcomes with a few variables?
I mean, I don't know. It could be a limitation of the methodology. I mean, I think at the heart of the methodology that we struggle with is this problem that we cannot identify who actually has Medicaid coverage. And so we have to use the best approaches that have causal inference that we can. And I think there probably are some, you know, I don't know why it explains so much of the variance.
County in your expect soak up a lot.
It could. Yeah. Yeah.
It's funny to complain about how high it is, but it's terrible.
No, it's a red flag, right? Like it is.
Theoretic things that would affect this.
Yes.
Yeah.
No, it's probably
Yeah.
the fixed effects.
Yeah.
Yeah.
That's a good point. This paper's already published. I wish you were one of our reviewers because we could have looked at that. This is like a, you know, the retroscope or retrospectoscope would be nice to have. You know, welcome your feedback on the next paper where we can actually do something about it. I don't know. I think it is concerning. Yeah. So the sensitivity test with older borrowers, we actually see that among people over the age of 65, borrowing goes up in Medicaid in California counties, Medicaid expanding counties relative to non-Medicaid expanding counties. And when we look at the triple difference specification, you definitely see this relationship between people under age 65 having the reduction in comparison to people over the age of 65. So this, you know, my hypothesis might be that this might be what California trends would have been if there hadn't been Medicaid expansion, that maybe there was just a general increase, there would have been a general slow increase in payday borrowing in California in the absence of it. Alternative explanations, I mean, are really hard to kind of grasp at. Was there some new program that just impacted the elderly? Was there some new cost structure related to something? I don't know, but you definitely, you see the increase among people who are older than 65, and you see the large reduction among those under age of 65. So, you know, we, to the best of our ability, feel like we were able to try to answer this question. It would be fantastic if there were a data set that allowed us to actually look at people's coverage and look at that relationship to payday loans. As far as we know, there's no such data set that exists. So it's funny to live in a world where there is so much data, but when you want to answer a question that seems like it should be a reasonable question, there's no data. And so I think this is suggestive. But absolutely, it would be great if there were an ability to somehow link administrative Medicaid records with payday lending. You would need to get some kind of agreements in there with evictions, as we'll talk about. Like that seems like it's even more possible because you have address-based information. But with payday lending, it's very difficult. Now, the reason why we, you know, the issue of the secondary outcomes where you see increases, our only hypothesis related to that is that it might change the composition of borrowers. So people who might be borrowing for health care related reasons might be fundamentally different than people who borrow because they're underemployed or, you know, have a substance abuse problem or any other myriad of issues. And so that might be a higher risk population than people who are borrowing because of trying to fill routine prescriptions or because they had some kind of health shock. I think that also warrants future research. Now, because, oh yeah.
Did numbers of defaults, late payments, and rollovers go up, or did proportions of those things go up?
The proportions went up. Well, so the share default is a proportion. So among the remaining borrowers, they were more likely, the remaining borrowers, a proportion of people who defaulted, who rolled it over into new loans, or who paid late went up. So it is looking at the relationship between the new denominator and this outcome. And our thinking about it is that it's an actual change in denominator. You know, if you remove a lot of people because there's been, and we observed a significant reduction in payday loans, if you remove those people, what you have left is a different population. And they may have completely different socio-demographic characteristics. They may have different lending needs. But we can't know, right? Because we don't know them. So we can't answer that question with any kind of, rigor. So, as somebody who studies social policy entirely because I want to influence decision-making and policy, the question is did it have any impact on policy? And the answer is complicated. So we got a tweet out from Dianne Feinstein. The article was shared a lot. My favorite is that we had 26,000 upvotes on Reddit. Very exciting until you read the comments. And once you read the comments, you despair for humanity because people are having this entire scientific debate about the article and nobody has read the article. So no, I mean, the paper was shared though in the Commuter Financial Advisory Board, and I think that, that's the best we can hope for at this point. Did you have your hand raised? Okay. All right, so questions about this, yes?
What would you have wanted to happen from a policy perspective?
I think from a policy perspective, I would like people to recognize that Medicaid is not just a health policy, but that Medicaid is also, in many ways, an anti-poverty policy. And I think when people are looking at the costs and benefits of Medicaid, they often do focus entirely on the healthcare system. A lot of states use the Oregon experiment results in a way to suggest that Medicaid is not good value for the money because we did not find any change in blood pressure, cholesterol, obesity, a lot of the things that we had thought that maybe we would 2 years after people gained coverage. And the narrative around that kind of became Medicaid is not good health insurance, Medicaid is not working. And yet one of the important benefits of health insurance is to protect people from financial harm, these catastrophic exposures, and also to give them predictable healthcare expenses. And I think that, I don't know if people really believe this, but I get a sense from the policy, the way that policies are made, that there's this belief that low-income people don't have any finances to protect. Like you can't get blood from a stone. So they're charity care anyway, they're not paying their bills anyway. And yet low-income people do have finances to protect and they're precarious. And so, and things like payday lending, while I do see the purpose of having somewhere that people can go when they have no other options to pay bills that they have to pay, I do see that argument. It can cause people to go into a debt spiral. You keep rolling these loans over and paying more and more fees, and you have the same amount of income coming, like where are you gonna take that money from? And so my hope from a policy perspective is that we can broaden the conversation about Medicaid to include these benefits that traditionally have been lumped more into benefits related to earned income tax credit or benefits related to TANF. And I think that there are more and more studies coming out to support that, and so that's kind of my goal. I haven't seen that happen per se, but I'm always hopeful, right? Like we do the work because we hope that people will read it and respond to it, and any legislature that wants me to come and present, I would happily do so on my own dime, because I think it's important information to consider, even if we can't get at the answer definitively because of the limitations of the methods. Yes?
Question. The organization, the professional association that you got the data from, did they react to the potential implications to their business?
Well, so one of the theories we bantered about when we were looking at the change in the composition of borrowing behavior among the remaining borrowers was this idea that they may have, if they did increase or have a substantive decrease in borrowers, that they may have then taken on riskier loans. We did not get a reaction from the trade association. To be fair, they had their hands full with federal regulations that have been in the works for a while, and I think that we have tried to present it as neutral to whether or not payday loans are good or bad, but with the conclusion that a reduction in payday loan borrowing is good, right? Like, I am a little agnostic.
ACA is bad for their business.
They have not responded to that, no. I think what's worse for their business is the federal government putting the stop to, you know, their kind of freewheeling lending practices. I think that we are small potatoes compared to the bigger threats that they face, which is both state regulations and all of the inquiries that have been done at the federal level into whether or not this is harmful. All right, we ready to move on to the paper that is work in progress? So I'm scared of you because you know, generally in my field, you present work that's already been published, and so you've had several levels of people telling you, oh, this is wrong, and this is wrong, and this is wrong. And the only place that I've really seen people present works in progress is in meetings of economists, which is like a bloodbath. So, I mean, really, truly, as a social worker trained person, I'm like, are you okay? Are you all right? Do you need to talk after the meeting's over? I'm here for you. Let me know if you're having any suicidal thoughts or feelings. You're not worthless. You belong. Yeah, so know that I'm a little nervous, but I do welcome your thoughts and feedback on this. So as you know, in my introduction, I talked a little bit about this, but health, you know, there is good reason to believe that health declines could contribute to evictions. Merely just in providing some competition for limited resources, any money that you put towards healthcare when you're very poor can conflict with other necessities, which include housing. And actually, a paper by Tom DeLear and Helen Levy looked at what people bought when they didn't buy health insurance, and it's housing. That's where people's money goes. So there is very clearly a relationship between this trade-off. And then there's the mechanism of potential labor force participation, which is simply that, you know, you're playing soccer, you blow out your knee, you're uninsured, you're a laborer. You may not be able to work, you may not be able to pay your rent, you could become evicted. There is a lot of emerging research on the harm that happens to people when they experience an eviction. And so we have reason to care about people's health once they've been evicted. There's been studies to show that people, you know, under stress start to engage in riskier health behaviors and that they have poor mental health outcomes, which makes perfect sense. There's a lot of despair, I can imagine, associated with losing your housing. And there's also, you know, the possibility that if you lose your housing, that you could just become homeless. And the health exposures and homelessness are very well known and documented and have been associated with increased mortality and, you know, obviously, which is the most terrible of outcomes. There's also been the argument made that when somebody is evicted, that they're displaced from their community, and that includes the healthcare network that they may have been involved in. So they may no longer live near their clinic. It may be, you know, impossible for them to get there, and there can be some disruption to the continuity of care. These are all kind of just reasons why we think there might be this relationship here. And we believe, you know, like we mentioned earlier, that there is reason to believe that Medicaid expansion could impact people's finances enough to help them maintain more stable housing or to improve their health and well-being enough that that contributes to their ability to maintain stable housing. So we purchased data from this Russell Sage, from this Russell Sage Foundation grant from a commercial a commercial company that provides evictions data to rental companies or potential landlords. And I'm gonna come back to that because I think that's a discussion point worth having. So it's used to screen tenants. And we have monthly evictions data in 289 counties from January 2019 to December 2014, which is right before the ACA Medicaid expansion started. And again, that's about 24 months before and after California's Medicaid expansion. Now, the dark is the the percent of counties treated by Medicaid, and you can see that Massachusetts had an early expansion and Hawaii had an early expansion, and we consider those counties always treated.
A question about the data set.
Yes?
So does this vendor include the individual vendor or is just the corporation only?
Can you repeat that?
So like, does this database is only for the like big company that you report to?
Oh, no. So this company, so evictions are public record. And so this company it collects from, it has contracts in place with all of these different cities within counties, within states to collate the records of evictions so that they can be used as a screening tool. And again, I'm glad you brought that up because that comes back again when we talk about what I want to talk about, which is the use of data like this in studies like this. So our approach was, again, the difference in difference design because, again, there is no data set that we're aware of that links Medicaid records to evictions. And actually, it would probably be very difficult to do because once you've been evicted, your address is no longer that address, right? You have to move. And so when you enroll in Medicaid or the address changes would make that very difficult. This time we're looking at evictions per capita, the number of evictions, and then the natural logarithm of the number of evictions. Evictions per capita and number of evictions are very similar measures. But the reason why we look at them separately is per capita accounts for the size of the county you're in, but evictions don't happen at the individual level. Evictions happen at the household level, and evictions are only impacts adults. I mean, the children get evicted, but they are applied only to adults. So looking, you could have a household that has 3 children and 1 adult, and that the child is not going to be included in the eviction measurement. So we can't do that. So that's why we also look at number. We have 51 early Medicaid expanding counties, and we compare that to 235 counties in 13 states that didn't expand. We aggregate to the county month. And then we ran a number of specifications to ensure that the findings weren't dependent on any particular state being included in the data set or excluded from the data set. We did run county-specific linear controls for time, allowing the eviction trends to vary by county in this paper. And the standard errors were clustered on the county. And we did, again, stratify on, this time, median share of previous uninsured compared to, so high versus low of people below 138% of federal poverty level. We also did some alternative analyses. Did you have a question?
How do you account for the fact that the early years were just concurrent with the recession and everything? With the, I mean, I would imagine the evictions would be higher.
I mean, so we can't, it's not a total overlap, right? 2000, but we would expect that the recession was a national recession, and we would expect that that would impact our county controls across the 13 states the same way that it would California. Also, the recession impacted a lot of homeowners, and this is a rental market, so it might behave a little bit differently than, but there certainly are, when you're looking at the possibilities of things that could bias it, it could be that the rental market became tighter because more and more people lost their homes and they had to turn to there are things that, are definitely worth thinking about related to that. But we hope that the design accounts for the time trends nationally. So to try to get at, to look at this from some alternative perspectives, we did a synthetic control approach, which has become more popular in these kind of analyses recently, and we match counties by their pre-expansion trends. There's a variety of ways that people do this, but this made the most sense to us. We also have limited information. And we do that for the period of time May 2009 to 2011. We use an exact inferential technique. We create a false Medicaid expansion data 2012, and we randomly select these group of control counties and calculate the average distance between the actual counts and then the synthetic controls that we had randomly selected. We do that 4,000 times to create this kind of pseudo California collection of counties over each time that we run it. And then the p-value we construct through the share of randomly selected differences that were larger in absolute value than the difference that we observed in the California counties, and I can show you what that looks like. And then we also looked at the national data that was available through, it wasn't when we started the study, but when we were finishing up, through the Princeton Evictions, University Evictions Lab. That's Matthew Desmond's public data set. It's a really cool data set. He also uses the ERRS data for the states that we use, but he also has data from different sources that fill in the rest of the country. And he was able to construct a longer, what he has that we don't are a bunch of control counties and control states. So because we were limited to this ERRS data set, and there were only like 2 states that didn't expand Medicaid in 2014, we didn't have the variation necessary in that data set to be able to look at 2014 expansions. But of course, the big question with the study, the way that we did it, is this generalizable to ACA expansions? I mean, that's really what people want to know, right? And so we were able to use this data, which is not as precise as the data we have. It aggregates evictions to the year, not the month. There's some measurement issues that they have done their very best to address, but it's a little bit imperfect. But we basically replicate our analysis using their data to see if the results that we get are similar. And instead of per capita, he had a great measure of rental occupied housing, percent rental, which I would like to find for our paper if we can, but it's, I'm not sure that we'll be able to get it. I'm not sure exactly even how he got it. So this is our event study regression. As you can see, in California, the evictions were higher prior to the Medicaid expansions than they were in comparison counties. And then over time, we see a flip-in sign where eviction rates went down in Medicaid expansion counties. And this is what our difference in difference regressions look like. We see the reduction in the number of evictions, the log of evictions, the evictions per capita, and the numbers below are the county-specific linear trends included into the model. So what you see here is that we have a decrease in the magnitude of effect when we count for county specific linear trends in our models, but they're still significant for the most part. And again, we have that high R square. Again, I don't know why. But it's something I can bring back and we can talk about, and we can try to see if we can come up with a reason. And maybe the reviewers will mention it. In fact, I was really scared I was going to get the reviews today because I got an email last week that said, your paper has finished review. You can expect, our feedback very soon. And I was like, please don't let it come on Tuesday. Please don't, because basically I'd come in here and be like, never mind. I've heard from the reviewers, it's not a good paper, never mind. But we have time to try to look into that issue. And then we did see a bigger reduction in counties with the high share previously uninsured. We can't do the age-related analysis that we were able to do with our paper because we simply don't have that information. But you do see here that the reduction in evictions did occur in counties that had the previously higher share of uninsured and wasn't observed in the same way with those that had fewer uninsured. And so in terms of our main results, again, we don't have a lot of outcomes here and not a lot that we can do with the data, but we think it's the best data that people have so far. We believe that Medicaid association was, that Medicaid expansion was associated with a reduction in the rates of eviction when we compare them to comparison counties. And we do observe this change in sign. We found the reduction in evictions in general and per capita, and when we include the county-specific linear trends, we still see statistically significant differences, but of a smaller magnitude. This is what our synthetic control models look like. So it's a little noisy, but you can definitely see a clear divergence following the expansions in 2012. So that's reassuring too, that our findings are related to a divergence in trends and not just related to some unobserved trend related to California specifically. And this is what our synthetic control, it's very hard to read, but the important thing is that you don't see statistically significant differences as you create it, and that they become increasingly statistically significant over time. So you have that divergence and trend that's observed following the Medicaid expansion. And when we look at the Evictions Lab Analysis, we find consistent results almost to the same magnitude. So we find that when we look at all of the states, which are included in the data set, that following the 2014 Medicaid expansions, looking at year effects, we see a reduction in Medicaid expanding states compared to those that didn't. And that's true also when we control for county-specific linear trends and year fixed effects. And as you can see, that's true also when we're just looking at evictions per rental occupied household. So we think this is important because we believe that evictions are truly a terrible outcome. How many of you have read Matthew Desmond's book, Evicted? It's a really upsetting book. I mean, he follows these different communities where evictions are really high. He interviews landlords, he interviews tenants, and the humanity of the experience is very visceral. So you really get the sense of how people's lives can cascade out of control when they lose their housing. And the amount of stress that it causes families, and even what it does to their potential ability to get housing in the future. Precisely because of data sets like the AIRS data set, they are likely to be driven into an alternative rental market, which rents specifically to high-risk tenants, and they do not have the same quality. They charge a lot more. And so it's like double, triple jeopardy that people find themselves in. So now you have a record of an eviction. So now you have to go to a place that is in an unsafe neighborhood where the landlord doesn't keep it up to date. You can have environmental exposures related to lead paint and faulty wiring and electricity. And then to make matters worse, you're paying more for that place than you were paying for the place that you got evicted. So if you had financial strain before, it becomes compounded. And so we think that it's a really important outcome to consider. And it's also important to consider because Medicaid itself has started to look into housing as a way to lower healthcare costs. So many states around the country have been looking into housing first programs, you may have heard, which is basically before we try to engage people into substance abuse treatment, before we try to do, all of these intensive interventions, they need a housing. They need to be in a safe place before we can do anything. And so if Medicaid is going to be investing in housing, that speaks to the importance of housing for low-income people. And taking the Medicaid intervention out of the picture, it seems to us like Medicaid itself might be improving people's housing stabilities. So this adds to, I think, what is a compelling literature on the impact of Medicaid expansion on people's finances. Again, we have the limitation of we cannot link people's Medicaid records so we have to do the very best we can to try to do as many things as possible to validate our approach and to hope that what we're really capturing is Medicaid. But there are definite limitations to the data. And then speaking of the AIRS data, we have the data for another 6 months. And while I'm interested, I'm definitely obviously interested in the impact of Medicaid expansion on preventing evictions. I'm also really interested in the reverse. So would there be a way of looking to see if some kind of health impact, actually if you could prospectively look to see if some kind of health shock led to an eviction and the role of insurance, and then what happens. There has been a little literature on what happens once people are evicted. They tend to use emergency department more frequently, so there's that kind of effect. But I wonder if Medicaid patients, if their utilization goes up and eventually goes back down, or if it goes up and stays up. You know, like what are the long-term impacts for a program like Medicaid, who might cover people for years and years and years, of allowing eviction to happen? So there's a possibility of trying to merge with data sets, but we have not been able to think of a merge that wasn't fatally flawed methodologically. Any suggestions you have on that, we welcome. But we haven't been able to get to it. And then, I don't know if any of you saw, but there was an article about Matthew Desmond's work written by a professor at Portland State, and her name is eluding me right now. And she co-authored it with some community activists. And she really criticized him for using the heirs data, because she's like, you're taking, in the name of doing good, you're taking research money and you are feeding the beast that then makes it harder for people to get housing. And I am interested in that. Like I am a social worker by training. I do this research because I care about the health and well-being of low-income people. And it's true, we paid for the data. And that data increases the capacity of this organization to collect more data and to engage more landlords into screening tenants. And I have really mixed feelings about that. And I think that as researchers, we don't have enough discussions about how much harm we're willing to do in the name of doing good. And I do think that this research is important, and I think that this is the kind of research that can do good if it expands people's understanding of the Medicaid program and the benefits to low-income people. But I'm wrestling with that, and so I welcome your thoughts. And thank you for attending. I hope lunch was good.